I'm Steve Scully with the Bipartisan Policy Center. It was mid-March 2 years ago, the World Health Organization, and here in the US, President Donald Trump declaring COVID-19 a national emergency. So where are we 2 years later, and what is the path moving forward? In just a moment, my colleague, Dr. Anand Parekh, is going to be joining a conversation of leading public health experts on what's next. He is the Chief Medical Officer here at the Bipartisan Policy Center. But we want to begin with Dr. Rochelle Walensky. She is, of course, the Director of the Centers for Disease Control and Prevention. Dr. Walensky, thank you for being with us here on behalf of the Bipartisan Policy Center. And I want to begin straight up with where we're at this moment and when will it no longer be considered a pandemic?
I'm delighted to be with you here, Steve. Thank you very much for the opportunity. We're in a much better place now than we were just a year ago. Certainly cases are coming down, that's encouraging, but we have so many more tools now than we did even just a year ago. So vaccines, boosters, certainly that are demonstrating protection, certainly against severe disease, illness, and death. We have therapeutics that we didn't have a year ago. We have our monoclonal antibodies, we have Paxlovid, molnupiravir, those that are keeping people out of the hospital. And then we have a lot of testing that is happening, rapid tests that people can do for that extra reassurance before they gather. So many different tools. What we are thinking about and looking at moving forward is, everybody is empowered to use these tools. We are working to make sure through our launch of our community, COVID community levels that just happened a couple of weeks ago, to really focus on severe disease, to focus on hospital capacity, and to make sure those who are vulnerable have the protection that they need.
As you know, there are a couple of debates going on right now. Certainly the funding issue on Capitol Hill, new concerns over the BA.2 variant that is in Europe and now showing here in the US. I want to get to that in just a moment, but there's also a renewed discussion over a fourth shot, a second booster. What is your view on that?
So we at CDC have been following the vaccine effectiveness studies very, very carefully. We have numerous different platforms in order to do so here in this country. We follow it in our multi-jurisdictional platforms that can look at about 2/3 of the American population now and see how they're doing with regard to the vaccine waning. We can follow it in our hospitalization cohorts and even in our cohorts where we follow people and swab them every 2 weeks, every week. What we're seeing now is that we still have quite a bit of protection against severe disease, about 78% protection against severe disease among those who were boosted first. So among those who were boosted 4 to 5 months ago. We are continuing to follow those vaccine effectiveness data very, very carefully. There was just a paper out of the New England Journal of Medicine yesterday from Israel on the effectiveness of that fourth shot against infection. And so as we are following those data, we're also working within the FDA and with our pharmaceutical partners, of course, to understand the benefit of that vaccine, that fourth shot, the timing of it, and in whom it should be recommended, in the weeks and months ahead.
That really leads to the question, as a medical professional and public health expert, the natural immunity that one might get after having contracted COVID-19 versus vaccine immunity. Can you address that?
Yeah, this is an area of critically important study. In November, we put out a scientific brief at CDC demonstrating and discussing all of the studies that have been published to date. Just about a month ago, we had a study out of California and New York that demonstrated if you've previously had disease, that you actually have quite a bit of protection, perhaps even more so than those who had been vaccinated and not yet boosted. Here's the challenge, though. That study out of California and New York was before Omicron, and it was also before widespread boosting. So it's not entirely clear how that protection works in the context of Omicron and boosting. There was just a study published in the last week or so that demonstrated if you had prior disease, you're actually pretty well protected up to about a year against the Alpha variant and the Delta variant, but really poorly protected against the Omicron variant. So if you had disease a year ago, your protection against Omicron was about 13%. Even if you had protection up to an infection about 3 months ago, your protection was really only around 40%. Here's a piece of good news, though. There's a recent study out of Qatar, a large study that demonstrated if you've previously had Omicron, that you actually have about 95% protection against BA.2. So we are still learning quite a bit about infection-induced immunity. And one of the challenges with implementing what we're learning is that we still don't have an FDA-approved diagnostic test that we can use in commercial labs for patients to say, you have protection either because you've been previously vaccinated or because you've had previous disease.
Which really goes back to the opening question. Dr. Walensky, is this the new norm moving forward as we look at the path ahead, not only this year, but in the years ahead, dealing with different variants of this illness?
Yeah, I think, as we think about what it looks like to emerge from this pandemic, I think many of us are tiptoeing out. Many of us want to be done with it already. I think one of two scenarios can play out, or perhaps even both. Over time, this may very well become a seasonal disease where the amplitude of disease, the amount of disease that's out there gets less and less over time. And that may very well happen. So the severity may be less, the number of people who are getting sick may be less, and it will impact our lives much less because we all have a lot of immunity to it. In fact, our recent studies demonstrate that about 95% of America has some sort of protection against COVID-19, either by vaccination, boosting, or prior disease. The big unknown here is a future variant. With disease that is replicating in other parts of the world, and even here, every time we have transmission, we have the opportunity for a new mutation and a new variant to emerge. And so we're watching that very carefully. We're working hard to vaccinate the world. But if there were a new variant, what does that mean, both in terms of severity, ability to escape the protection that we have, and in terms of all of our medical countermeasures?
So let me ask you to address this new variant, the BA2 variant, which is now popping up here in parts of the US. It seems, based on news reports, to be spreading in parts of Europe. What should Americans be concerned about? What are you concerned about?
Right, so maybe first let me just chat a bit about BA2. So BA2 is also Omicron. It's a sublineage of Omicron, and it is probably the reason that we get so much protection from being previously infected with Omicron against BA2. What we're seeing with BA2 is not really any more severe disease, not any more immune evasion than we saw with the original Omicron. We do see that it is a bit more transmissible. Some have predicted 30%, others have predicted 80% more transmissible. We've known about BA2 in this country since really about mid-December, didn't have a lot of it. And just this past week, we demonstrated about 23% of our sequences are Omicron. So it is increasing, but it's an increasing percentage of a much less absolute number of cases. So we aren't seeing this massive takeoff of Omicron, of BA2, but we do anticipate that we will see more and more of it, and it may become the predominant variant in the weeks ahead. In terms of what we're seeing in the UK and other countries is certainly more BA2, it is more transmissible, but all of this is happening also while there's waning immunity, as we've talked about in terms of following that for the fourth shot, but then also that the communities and population has opened up. They've relaxed many of their mitigation strategies, as have we. So we continue to follow this carefully. We're in touch with our colleagues overseas routinely and to understand what they're learning. So far, while they have had a slight increase in their hospitalizations as well, those hospitalizations we believe are not really severe hospitalizations related to Omicron, but people coming in with BA2. And so we're following this very carefully. We might expect, as we open up as well, as we relax many of our mitigation strategies, that we may have some increase in cases related to BA2.
And of course, as you well know, you have led the effort to reduce the mask mandate across the country, now down about 90% coast to coast. Do you see any reason why a mask mandate would be re-implemented at some point into this year?
You know, I certainly think it's possible. Certainly we at CDC don't impose mandates. We provide recommendations and guidance for when we believe that people should consider stronger mitigation strategies. What we have said as we release these new COVID-19 community levels is that we want to make sure that people have an opportunity to relax their mitigation strategies when things are good, as they are right now. Our hospitals are not full, but then that they should put that mask in a drawer, because if we have more cases that occur in the winter time, if we have more cases that occur because of a new variant, we want to make sure that people have had the opportunity to take those masks off so that we can re-implement them and protect people should we need them again.
So if you could, let's discuss briefly the public health debate, which includes funding on Capitol Hill and preparedness across the country. As that debate moves forward, what are your general thoughts?
So several really important thoughts I think that would be helpful. First, we came into this pandemic with an incredibly frail public health infrastructure that did not have longitudinal funding over time, that got boosts of funding from challenge to challenge. We came in with 60,000 public health jobs in deficit, and that is after a decade of H1N1, Ebola, Zika, and now COVID-19. We still had tens of thousands of jobs in public health that were in deficit. We came in at a time where our laboratory infrastructure was not there, where our data infrastructure was not there, that our pipes were not connecting to allow the data systems to flow. Now, we've made huge strides during this pandemic, but it has demonstrated that we have much more work to do. So we do need, I would say, disease agnostic, longitudinal resources so that we can skill up our workforce so that we can get our laboratories in top-notch shape so that they can do genomic sequencing across this country, not just for COVID, but for many other things, and that we have the data systems. Now, in addition to the resources, I want to make it very clear that one of the big challenges of this pandemic for CDC specifically has been our data authorities. While people have asked of us to report vaccinations among those hospitalized, CDC does not have the authority to collect those data. We rely on data coming in voluntarily from us, to us, from jurisdictions, from states, in order for us to be able to compile it, analyze it, and report it outward. And so one of the things that we're really asking for is to work harmoniously, synchronously with the states and the jurisdictions, so we get data in real time and that we can report those data then back out to them.
And so your message to Congress is what?
Message to Congress is an investment in public health and public health infrastructure such that we do not have to sort of scramble from one infectious disease challenge or one health challenge to another. Longitudinal resources so that a physician or a public health servant could serve in a public health jurisdiction and have rest assured that that job will be there in a year for them to continue. And then also that there are authorities for CDC so that we can actually deliver on all of the data requests that are coming into us in a privacy protected way.
So let me conclude with essentially where we began. How do you keep the public engaged? It has been now 2 years. We are into the 3rd year. As you know, in your own family, with businesses, with schools, people have grown weary of this pandemic.
First, I just want to say that we need to acknowledge that this country has lost nearly 1 million people and that people are hurting. And if we expected anything, and that's just with the deaths that have been suffered, and then many of the things that you've layered on top of that. Challenges with jobs, with people being sick, with people being home and out of work, with the economy. So I think we need to acknowledge that this has been extraordinarily hard, and that while we can count COVID cases, we can't necessarily attribute and count all of the other issues that have occurred related to COVID-19. And so we need to acknowledge those, and we need to make sure that as we put our public health guidance out, that we do so taking not just what's happening with COVID in mind, but everything else in mind. And we continue to do that. I am encouraged in the current moment of where we are now, the medical countermeasures we have, the incredible scientific progress that has been made. We at CDC are committed to delivering guidance that is timely, that is based in science. Sometimes that means that the science is going to be gray. It's not going to be black and white because we have to deliver timely guidance that's based on epidemiology and where we are, and that is implementable and feasible across the country.
So do you have the resources necessary to deal with COVID-19? And as you pointed out, that is not the only issue that you and your colleagues and the incredible staff at the CDC have been doing for so many years.
As we look to the resources that we need in this current moment, and I know that there is an ask, one of the things that is challenging, well, we have numerous areas that I think are really challenging the CDC right now in terms of what we need to deliver. Certainly, if we are going to embark on 4th doses either now or in the future, we need a mechanism by which we can not only purchase those, but then deliver them, administer them, get out to those communities, make sure that equity is a huge part of it. Those take resources. The resources, for example, to deliver on our vaccine effectiveness platforms. Those, we have numerous vaccine effectiveness platforms, and some of them where you have, hundreds of thousands, tens of thousands of patients. So we need the resources to continue those platforms, the data collection, data analysis to our academic partners who are doing those with us. People are asking, and we are engaged deeply in survey data and healthcare record data on long COVID, longitudinal data. What is the impact of long COVID? Those are data that are going to take 3 years for us to really see the longitudinal impact of this disease. And we need long-term funding in order to be able to do that. And then finally, I will say, in order to deliver vaccines to the rest of the world, we need, and that is not just to protect those there, but to protect us at home. We need to be able to implement global vaccine strategies. CDC has offices in 60 countries around the United States. I've been speaking to many of those country directors about the challenges of vaccine delivery and administration in those countries.
You are a doctor, but you're also a mom. So final question to the moms and dads out there thinking about spring and summer plans, thinking about their kids now back to school, thinking about the year ahead. Your message to them is what?
Oh, it's been so hard. The last several years as a parent have been so hard for so many people. You know, in the springtime, I tend to be optimistic in general. Springtime, there's so much that we can do outdoors. I would say cautiously, optimistically plan those summer plans, do as much outdoors as you can. And I am looking forward to what I hope will be a really productive year ahead.
Dr. Walensky is the director of the CDC. We thank you for your time and perspective today.
Thanks so much for having me.
Dr. Anand Parikh is the chief medical officer here at the Bipartisan Policy Center. He will continue the conversation, the path forward as we deal with now this third year of COVID-19. Anand?
Steve, thanks so much. Thanks to you and Dr. Walensky for that informative conversation. Clearly, we're not quite through this pandemic, but are at a point where you can start to think about how to come out of it, as well as how to prepare for future public health emergencies. We know that the pandemic has had profound impacts on our healthcare system and our healthcare workers who have been heroes during this pandemic. A key policy tool to facilitate the care of patients and broader public health actions during this pandemic has been the declaration of a public health emergency by the Secretary of Health and Human Services. As an example, it's this declaration that has allowed many of the tools of the pandemic that Dr. Walensky talked about, from tests to treatments to vaccines, to be accessible to the public. This declaration was first issued on January 31st, 2020, and has since been renewed 8 times every 90 days. It's next set to expire on April 15th, though it's widely assumed that it will be renewed at that time. I think it's important to note that we don't know how long this public health emergency declaration will be needed, partly because this virus continues to evolve. And the science should ultimately dictate whether the declaration is still necessary to keep Americans safe. So it may be July, it may be later. I know we all want to be done with this pandemic, but it's important that we treat this not as some symbolic action, but one that puts the public and the patient at the center. Now, we do know at some point in the near future, this declaration will end, and there will be profound implications for our healthcare system. Joining me today to talk about these implications are 4 leading healthcare experts who plan to discuss how aspects of access and delivery and payment of healthcare services have been influenced by the public health emergency and how these practices may evolve as we come out of the pandemic. We're very pleased to have with us today Matt Salo, Executive Director of the National Association of Medicaid Directors, Fred Bentley, Managing Director of ATI Advisory, Mei Hua Kwong, Executive Director for the Center for Connected Health Policy, and Dr. Jeff Barr, Chief Medical Group Officer, Advocate Aurora Health. Just a reminder to the audience, please feel free to send your questions in via Facebook or Twitter, and we'll try to get them in today's discussion. So Matt, perhaps we can start with you. As you know better than anyone, the public health emergency has had significant implications for the Medicaid program, and its eventual end will be equally impactful. Can you talk us through what we might expect moving forward?
Sure. And Anand, thanks for having me here, and thanks to the BPC. And it's certainly an honor and a privilege to follow the CDC director. So I thought I'd level set perhaps just a tad about Medicaid and its role in the healthcare system pre-pandemic, and then how that has changed and what that means through the pandemic, and then what does the end of the public health emergency mean for it. So, Medicaid pre-pandemic was the largest health insurer in this country. We covered 71 million Americans. We provided coverage for more than 40% of the births and all kids in the country. Medicaid was the largest provider of behavioral health services, and it has always kind of been the nation's long-term care system. That is pre-pandemic. It is an important program. And one of the things that we've seen that's been really important is that Medicaid has been, and this is not the first time, but this is the latest instance of Medicaid serving as kind of a first responder for the nation in dealing with a major crisis, whether that be economic or pandemic related, natural disaster, et cetera. And so very purposefully, Congress created a dynamic where throughout the pandemic, no individual who was on Medicaid or who got Medicaid coverage was to lose it essentially for any reason. And that has been really, really important for a number of things. First, for the stability of the nation's economy, but also, and arguably more importantly, for the physical, mental, behavioral, social, and economic health of Americans and the people we serve. So Medicaid has been an incredible lifeline through the pandemic, and I think it's really important to acknowledge that. So as you said at the onset, although it is unpredictable, we know that the public health emergency ends at some point. Will it be mid-July? Will it be later? Not sure, but it's coming. And kind of the obvious dynamic is that will trigger we call it the unwinding, but it's going to trigger a pretty significant dynamic shift in how many people are covered by Medicaid. Because we went from 71 million Americans. As of September, there were 84 million Americans in Medicaid and CHIP. And I suspect that by the time we're out of the emergency, we may well be north of 90 million Americans. And I think the estimates are there could be as many as 16 million of those individuals currently on Medicaid who will no longer be eligible for the program. And I think it is appropriate to say, how do we manage that dynamic? But I think it is also appropriate to say, you know what? The system worked. The system did what it was intended to do, and it ensured that a very large number of low-income individuals who are worried about the pandemic, worried about their jobs, worried about their health, have been covered and have remained covered throughout much of this troubling couple of years. That does not diminish our obligation and our opportunities to ensure that the transition of those individuals from Medicaid to wherever their next home for healthcare is going to be, that is very, very important. But I think it's also important to know this is not going to be 16 million people who lose healthcare coverage. And it has been for quite some time and will continue to be the absolute number one priority, not only of our association, but for our members across the country in every state in the country to say, how can we ensure that this transition goes off effectively, efficiently, smoothly, appropriately, and humanely? And this is going to be a really big task. And it is going to involve an enormous number of moving pieces. It is going to involve an enormous amount of partnerships that we need to build upon. That is going to be state-federal partnerships, state Medicaid programs and our federal partners, not just the CDC, but more importantly at CMS and CMCS, our equity partners of the federal government. But it's also going to involve a lot of public-private partnerships. And part of what states are doing right now is saying, how can we partner with, how can we leverage entities like managed care organizations, community-based organizations, provider groups, anybody who's got an interest in the health and the success and the stability of the Medicaid program. We're calling on them to work with us to ensure that the process is going to be smooth and that, priority number one, people who are still eligible for the program at the end of the public health emergency remain on the program appropriately so. But priority number two is to ensure that those who are no longer eligible, that we find a way to help transition them to their next health insurance home. Again, whether that's people who have gotten jobs and have access to employer-sponsored insurance, or whether it is individuals who are going to be newly eligible for subsidies to buy coverage through the marketplaces, which will be an interesting dynamic because a lot of those folks will have transitioned from a robust Medicaid covered package with very, very little beneficiary cost sharing requirements, almost no premiums, copays, or deductibles for any reason for tens of millions of Americans, to a marketplace where, as we all know, the affordability can be a challenging dynamic. So these are all of the things that we are paying attention to very, very closely right now. It is as I said, top of mind for our members to ensure that this transition works well. But again, I would just reiterate that this is also an opportunity to say, Medicaid did its job, and Medicaid was a really important component of ensuring the health and the stability of this country and the people we serve.
Matt, very helpful, very thorough. Thank you. I want to bring the other panelists in. Certainly, the implications of loss of Medicaid have impacts on telehealth, Jeff, on solvency of hospitals, health systems, particularly in rural America, those that depend on Medicaid reimbursements, certainly Fred and the post-acute environment. Anyone want to comment specifically on Medicaid?
So Annette, I'll go ahead and start. First off, thank you for having me here, and also thank you for including Matt because he really touched upon an important area for telehealth. As maybe some of your audience members know, telehealth has actually seen a large increase during the pandemic. It was recognized as a very valuable tool during this time. And what most people might be familiar on what's been going on at the federal level with telehealth policy, where Congress just recently, passed the budget bill, the president signed it, and we know at least when the public health emergency is declared over on the federal level, we'll still have some of these temporary waivers that were in place, at least for Medicare, for an additional 5 months or so after the public health emergency is declared over. However, what people need to realize is CMS and Medicare policy were not the only things that impacted the utilization of telehealth. Telehealth was being used on the state level in the Medicaid program, and with 51 different jurisdictions, if you include DC, they all did things a little differently in how they approached telehealth and what they would allow. Right now, there are states in various levels of where they are with their telehealth policies. Some have already rolled back some of them, so they are going back to pre-pandemic levels of like where they were with telehealth. Some have adopted permanent policies, and others have like delayed it for maybe another year or 18 months as they gather more data. So you have telehealth in different places at different levels on like what you can expect and how you'll be able to like utilize it. Now, I also want to preface that there's still some concern on like how far you can utilize telehealth, what you can utilize it for. Even as a telehealth proponent, I don't say you can utilize telehealth for every single situation. So there are going to be, still many situations where you need to see the patient in person. But it is definitely a valuable tool and useful tool that can be applied in many, many types of situation. Behavioral health, for example, is a very good example where telehealth has shown like high effectiveness, high patient satisfaction. But then there are other areas where, telehealth may not be the best type of way to deliver a service. So what you also have is a concern that was raised during the pandemic in that, are you perhaps maybe also creating inequities with telehealth as well too? Because telehealth is the use of technology to provide services. You need to use technology, the patient provider in different locations, but you need a way for those two parties to connect. So you need some type of way to connect them through broadband or some type of Wi-Fi in order for the technology to work. And as we know, not everybody has that access for whatever reason. Perhaps of their income status, perhaps because of where they just simply live. They may be in a rural area with the lack of connectivity, access to equipment. So even though we are expanding telehealth policies or could be expanding telehealth policies more, there is a concern that there may be some populations that might be left behind. Now, to credit of a lot of policymakers, including the federal government, there has been some type of investment or some investigation like how to address some of those problems. There's been a lot of investment over the last 2 years by the federal government, by some state governments in increasing connectivity and broadband, but there's still other things that we need to be concerned about, such as can people have access to the equipment that they need? Do people have the digital literacy to use them as well? So these are all questions that policymakers are struggling with and trying to address too, because they have a tool that they know can be useful, can be helpful, but they don't want to make sure that they're not inadvertently leaving some segments of the population behind.
May, thank you for that. Very helpful. And maybe I'll transition to Jeff. Certainly, as May has alluded to, this has been such an important tool, telehealth, for both patients, but for the provider community. But just thinking more broadly to healthcare providers, hospitals, clearly they've gone through an incredible period during this pandemic. The end of the public health emergency for hospitals, rural hospitals, telehealth. Walk us through some of the issues that the end of the public health emergency raises from your perspective.
Yeah, and I think before I jump in on that, again, thanks to BPC and thanks for hosting us today. I think these are critically important topics, and I think just to maybe jump onto May's points about telehealth. We went from a pre-pandemic state of 300 of our employed clinicians, and I work in a system that employs 75,000 individuals. Over 3,000 physicians, over 2,000 advanced practice clinicians. And pre-pandemic, we provided on the order of 13,000 telehealth visits, virtual visits, a variety of virtual modalities. And that was just 300 physicians and advanced practice clinicians. During the pandemic, that rose to 4,000 physicians and APCs, providing approximately 800,000 visits. And about half of those were behavioral health. So in behavioral health, where there's such critical need and access pinch points, providing telehealth visits extended our access and reach to patients when they needed us the most. But I think to better understand the impact of the sunsetting of the innovative policies and practices that developed during the public health emergency, you have to understand the pressure upon an integrated delivery network like Advocate Aurora Health, which is top 10 in the nation in terms of size and impact. And while COVID cases numbers in our hospitals and around the country are trending down, we're cautiously optimistic that we remain cautiously optimistic that the pandemic is nearing an end. That said, even though the worst of it may be gone, there's still a persistent strain on our healthcare workforce, heavy toll in terms of emotional and physical burden. Moreover, there are unprecedented challenges that have arisen in terms of severe healthcare workforce shortages, dramatic increases in labor cost. And in addition to high labor costs, we also face skyrocketing increases for key medical supplies, such as N95 respirator, masks, gloves, with extremely high markups in cost. Drug expenses were adjusted as well. So I think we faced extreme downward pressure in terms of finances as well. Like other integrated delivery networks, we were also forced to delay or reschedule non-essential elective procedures. We greatly reduced our normal service volume. This produced disruptions to care delivery that deeply impacted our finances, but also our promise to deliver excellent care, which we still did, but under great duress. In some ways, the post-pandemic world represents both the very best and very worst at times for hospitals and our clinicians that served on the front lines. A potentially improved regulatory framework offers great opportunity to help spur the next wave of innovative patient-centered improvements in healthcare delivery. We did work through the pandemic extremely well, largely owing to our size and scale. We were able to shift elements of our workforce, our nurses and physicians, from one county or one state to the other because of relaxations in policy around licensing, and that innovative policy implementation allowed us to be flexible in a variety of ways with our workforce, and allowed us to adhere to our commitment to help all people live well and focus on equity in care when that was needed the most. Certainly the pressure of the pandemic further marginalized already marginalized populations, whether it be different races or ethnicities, the frail or elderly, the disabled, people with transportation issues or communication issues. But because of innovative shift in policy that I think is threatened by the.
Hey, Jeff, so sorry to interrupt. Oh, great.
Yeah.
We lost your feed for a little bit,
Sorry.
but you're back. Sorry, go ahead.
Sorry about that. But basically, the innovative policies did allow us to reach a broader segment of our patient population when they needed us the most.
Terrific. Great. Thank you. And I think we'll come back to some of those issues. Fred, for a moment, let's move to the post-acute environment. Certainly flexibilities here as well during the public health emergency allowed many post-acute facilities to offload some of the surge that acute care facilities that Jeff was talking about were having. What happens, Fred, from your perspective when the public health emergency ends for post-acute facilities in the environment?
Thank you, the BBC team for having this critical discussion. And I think before getting into what does the end of the public health emergency look like, what are the implications for the post-acute world, it's important to understand that when we use the term post-acute, we're actually talking about an incredibly diverse array of providers. We're talking about everything from nursing homes, nursing facilities, to home health providers, to long-term acute care hospitals, which are specialized hospitals that really focus on managing and serving patients who require extensive ventilator assistance. And obviously during COVID, many patients, extremely sick patients, required that level of care from what are called LTACs, or long-term acute care hospitals. So we're talking about a really diverse array, serving a very broad array of acuity levels at post-discharge. So that said, there are some very common concerns across the post-acute landscape. One of those is the dwindling of the provider relief fund, right? The kind of the lifeline of funding from Congress to help providers keep their doors open, continue providing services. Those dollars have basically dried up. So that's disconcerting for a number of providers that really were relying on those funds. Workforce issues are every client I work with on the post-acute space, again, from long-term acute care hospitals to nursing homes to home health to hospice providers, massive challenge. Nursing homes saw their staffing levels drop 15% during the pandemic, and they have not rebounded. Many of them have not been able to staff back up. So that is a huge challenge. In terms of the technicalities around the end of the public health emergency, and Anand, as you noted, the waivers and some of the innovations that were allowed, there's concern there, right? So the context of this is that obviously as hospitals were overtaxed and packed to the gills with patients, they needed relief valves. So a lot of the restrictions and regulations that have been in place to really try and manage post-acute care utilization were relaxed and or waived completely, and have been during the public health emergency. So a good example of that is for nursing homes or for skilled nursing facilities, in order to get a patient, that patient has to have had at least 3 days in an inpatient hospital. So a 3-day stay before they go into the skilled nursing facility. That was waived. And so you did see, and I think it was about 15 to 20% of skilled nursing facilities, their patients were actually coming from the community or from a much shorter stay in the hospital. It is, an open question around what happens to those waivers. And there's a trade-off here, right? Because there's concern around if you lift those restrictions, do we see post-acute care utilization shoot through the roof? There are budget implications there. By the same token, I know a lot of those providers that we've worked with have done innovative things, and that flexibility has been really critical to them being able to serve patients, arguably, and certainly during the pandemic, and arguably beyond that. I guess the last thing I would say is that kind of alluding back to the fact that we're talking about such a diverse array of providers, they're divergent fortunes here. So home health really benefited during the pandemic insofar as there was an increased emphasis on keeping patients out of hospitals, out of facilities, out of nursing homes whenever possible. So they really benefited from that push to home care. It's also important to note that During the pandemic, as part of the public health emergency, CMS created a hospital at home program, or really ramped that up in a dramatic fashion. And that benefited home health providers, right? Because they were the providers out in the community that can manage patients in their home. So they've really experienced some significant benefits, and they're kind of in the catbird seat when it comes to post-acute care. I would argue that the long-term acute care hospitals, the LTACs, have also proven their worth. You know, pre-pandemic, there were questions around, is this excess capacity? Do we really need these facilities? I think they have clearly demonstrated, and the data backs this up, that they were a critical resource in a lot of communities to manage very complex patients who needed ventilator assistance. Finally, it's a different story when you talk about skilled nursing facilities. They've been much slower to recover. Their occupancy levels are well below where they were pre-pandemic. They're creeping back up, but very slowly. And then, as you all likely know, the Biden administration has indicated, and he gave a nod to this during the State of the Union, that CMS is intending or planning to ramp up scrutiny around the performance of skilled nursing facilities, set higher bars, higher performance standards around quality, as well as they've talked about setting requirements around minimum staffing levels, which is, on the one hand, everybody would love to have well-staffed facilities, no doubt about it, but for an industry that is struggling just to get back to where they were pre-pandemic, that's disconcerting. That's a big challenge. So again, some common concerns, but some divergence around kind of how these different post-acute settings are kind of faring and will fare in the post-pandemic world.
Great, Fred, thank you for that overview. Very helpful. There are a couple of questions coming in from the audience, and Matt, maybe we'll start with you. Two that have come in. You mentioned that up to potentially 15 million current Medicaid beneficiaries may lose coverage. The question is, where do these people go? Where are they going to go to still remain insured? And a second question related to the enhanced federal match, and does the idea of phasing down the current enhanced federal match after the public health emergency ends, does that have any legs? So two questions, Matt, if you can start us off.
Sure, great, and great questions. The trajectory of some of the individuals, again, those who are legitimately no longer eligible for Medicaid, will be some combination, and we probably should ask like the Urban Institute to give the exact numbers, but it's some combination of people who will have or be eligible for employer-sponsored insurance at new jobs that they have, or in a lot of instances, I assume the most instances, it is people kind of above the income threshold for Medicaid who are going to be eligible for federal subsidies to buy private insurance through the marketplaces. And that dynamic, as I mentioned, is going to be a challenging one because it is part of it will be helping to ensure a warm handoff, a transition, that someone who's on Medicaid now understands that they're no longer eligible and understands where they should go to find these new options and understand how to access those subsidies. But I think the real key piece is, even if that happens, what about a scenario where someone who has, again, spent a couple of years getting used to a robust benefit package, no premiums, no copays, no deductibles, now finds themselves eligible for a plan that's got a $5,000 deductible or significant premiums, and they'll look at that and say, I can't afford that. Sure, I'm eligible for it, but I can't afford that. And that's where I think you really need, and so I'll pivot the other part of the question into, really thinking about a congressional response to say, you can't ignore that piece around how do you ensure that if the marketplaces are going to be a legitimate form of coverage for individuals transitioning away from Medicaid, how do we ensure that the subsidies are at the right level to make them actually affordable so people take up that option? That's really important. So the second question is, what about kind of a smooth phase down of the enhanced federal match? That's been a huge component of the success of Medicaid through the pandemic. And I would say, does it have legs? Well, maybe. But I think there are definitely a couple of pieces that we have been asking for and we think are critically important. One of which is, yeah, you don't want kind of this cliff where at a date certain, the amount of federal dollars flowing into Medicaid just drops off in a significant way. That is disruptive. But I would also say that we're gonna see another problem, which is that the way the system is set up now, once the public health emergency ends, the enhanced federal match, which again has been so critical to keeping this going, the enhanced federal money is going to run out, whether it's abruptly or phased down. It is going to run out well before the obligation or the opportunity for the continuous coverage to end. So states will be facing a real world fiscal challenge of, how do we ensure that this process is as, as I said, as humane and effective as possible, while acknowledging that there are going to be some serious fiscal challenges if Congress does not kind of reconcile that problem and kind of force states into a dynamic of, we're keeping people on for an additional 9, 12, 14 months without any kind of sufficient federal support. That's going to be a real challenge, and I would hope that Congress is paying attention.
That's great, Matt. It's such an important point, and sort of on the same lines, your policy prescriptions, May, Jeff, and Fred. When you think about the end of the PHE and potential consequences that may compromise patient care, what are some policy solutions to ensure that we mitigate those consequences? So May, from the telehealth perspective, that which we've learned through this pandemic in terms of increased access to telehealth, leading to increased access, improved health outcomes, reductions in preventable healthcare costs. How do we make sure that those lessons moving forward are not lost? Same way, Jeff, the hospital healthcare sector, the hospital health system sector has learned so much. How do we make sure that when this PHE ends, we can ensure that patients still have adequate care, and same, Fred, in the post-acute environment? So your sort of policy prescriptions to mitigate some of the consequences that we may be facing later in the year, and May, starting with you.
Well, we're already starting to see some of those mitigation efforts. Again, on the federal level, what we saw where the telehealth policy was an extension of 5 months after the public health emergency ends, where some of the telehealth waivers, I have to emphasize that not all of them were in that budget bill. Some of the telehealth waivers will continue. Personally, I have a little bit of concern of, is 5 months enough in order to have that good transition? On the state level, we are seeing certain states have an extended period of time for their waivers. They have said that we will keep them around for an additional year or two. Part of that is for them to gather additional data. One of the other things that I did not mention earlier in these telehealth waivers and what we saw during the pandemic was the allowance of using audio only in order to deliver some services as well. And that was mainly because of touching upon what I said earlier about people not having access to the connectivity or the equipment in order to use telehealth through the video option there. So there are some jurisdictions that are extending those as well too, to either they have made some of those services permanent where you can receive them via audio only, a lot of that usually around mental or behavioral health. We've seen CMS adopt some of those policies as well too, allowing that to be a way to deliver services. So we are seeing some of these mitigation efforts right now. Are they enough? That remains to be seen, because there is still that concern that if you cut off some of these waivers entirely, or if you only have them around for a period of a couple of months, there are probably going to be segments of the population that are going to be left behind. So that is another thing that policies makers have been struggling with, is that how do we, not create disparities by allowing telehealth, but how do we not create disparities by limiting it so much that certain populations are just cut off completely? And that is definitely still a risk there. One of the things that I think the policymakers have been doing well is doing that extended time period of saying, having an additional couple of months or a year or two after the public health emergency in order to have that time to transition. Other mitigation efforts are allowing audio only to be used. And then other mitigation efforts are, as I mentioned earlier, addressing some of those barriers to telehealth, so addressing the connectivity issue, addressing the digital literacy efforts. So one thing that I hope they would do more of is around that digital literacy and like educating both not only the providers, but the patients more on how to use technology, how to access it, what does like a telehealth encounter look like. I think those should be things that should be stepped up as well. And, to credit to some of the policymakers, some of them are definitely looking into that.
Thank you, May, for those specific policy ideas. And Jeff, maybe moving to you, particularly hospitals and health systems, and I'm thinking now, we serve vulnerable Americans, rural America, many of those individuals Matt was talking about who will lose insurance, be uninsured, coming into your systems. How do we mitigate the consequences for hospitals and health systems?
I think May did a nice job of laying some of that out for us by improving and increasing access through virtual means. Certainly reaching out not only to those in our urban areas with transportation issues, but those in our outlying rural areas, certainly. And not just providing those services, but making sure there's technological infrastructure to provide those services as well. We have areas where Wi-Fi and 5G technologies simply won't hit for a while in our very own footprint. But beyond that, we need workforce. And it's not just food services and environmental services. It's physicians, nurses, and advanced practice clinicians. And I think Matt did a good job of opening up, where are these people going to go who are going without or are going to fall off of programs? Well, they're still going to come into our systems, and we need to seal the cracks through which they might fall, or else we're going to have a secondary pandemic of unaddressed chronic disease. We're going to have people who are going without routine cancer screenings or routine cardiovascular screenings, routine immunizations unrelated to COVID. So we have to make sure that we're addressing those needs as well, the behavioral health needs I addressed earlier. And so a lot of the waivers that we've enjoyed during the public health emergency have been fantastic. They've allowed us to be much more flexible with our workforce, utilizing and leveraging our size and scale across state borders. So that, waivers of practice limitations for nurse practitioners, some of those are state-bound regulations, but nonetheless, waiving those at the federal level has been fantastic for us. Extending residency caps so that we can train more physicians or prolong the training of some of our resident physicians whose training was interrupted by the pandemic. Having flexibility for physician privileging and credentialing processes so that we can get people working faster after we hire them, so they're not hung up in red tape. And then waiving the requirements for out-of-state practitioners to be licensed in the states in which they're working. We've had so much innovative policy implementation during this pandemic. Why punish ourselves for being creative in that way? We need to make doing the right thing, the clinically right thing, the easiest thing to do.
Great, Jeff, and thank you for your service and your systems service. And Fred, finally, certainly in the post-acute environment, I think everyone's in a little bit of a different spot, long-term care hospitals and inpatient rehab and home health and skilled nursing facilities. But again, once the public health emergency ends, how do we make sure that each of those important sectors are able to provide the care that Americans need?
Yeah, I think there are three big things that I see going forward. One is, and it's not the sexiest topic, but it is huge. It is stability in funding. And I'm not necessarily saying, a dramatic increase in funding, but specifically predictable and stable increases in Medicare Medicare fee-for-service rates. That is something that is always in the back of the minds of providers as they're planning for next year and thinking about staffing and what they'll be able to do and not be able to do. Is concern around is the coming year the year that we really start to see the hammer come down on us. So thankfully during the pandemic those rates really were pretty stable. So I think we still need that for the industry, at least for the next couple of years. Jeff did a fantastic job of describing the workforce piece, and I can't emphasize that enough. That is the rate limiting factor in terms of, and this does cut across long-term acute care hospitals, skilled nursing, inpatient rehab, home health, hospice. We are facing really significant access issues in just about every community in the US, on the physician side and the hospital side, certainly on the post-acute side, because we do not have enough staff. Home health agencies that just do not have the staff, the capacity to take patients. And guess what happens? Bad things happen to patients. Who takes care of them? It's us, the family members, the caregivers. So it is a huge burden. And I think that the federal government and the Biden administration indicated they, want to set minimum staffing requirements for nursing homes and try and address turnover issues in staff turnover, which is great. I also would argue we need funding there. We need creative programs in place to increase staffing in those in the post-acute sector writ large. And then finally, the waivers really have been, as Jeff and May have indicated, a great opportunity to do some innovative things. And I would say on the post-acute side, there's also this data now that CMS has around, okay, what happens when we relax restrictions around defining or redefine homebound for home health utilization, or get rid of or waive the 3-day hospital stay for SNFs. We've got some data now. We can look at what happened. Did it drive up utilization? Did it result in higher costs? What were patient outcomes? There's real data there, and we need to evaluate it. And I would argue that some of those waivers really should continue. The final thing I would say is that, as I touched on earlier, I think that hospital at home program, it's the acute care hospital or acute hospital care at home program is the technical term or name for it, has really spurred a significant revolution, maybe not getting as much attention as, say, telehealth and the virtual care revolution, but I would argue as important, a revolution in home-based care. So home-based primary care, home-based palliative care, SNF at home, skilled nursing at home, hospital at home. And it would be terrible to see those innovations and that momentum and that investment really be stymied in the post-pandemic phase.
Great. Thank you, Fred. So we have just maybe 2 minutes left. Just briefly, any final observations from any of you, messages you want to leave with our audience, policymakers, the public? Don't want to put anybody on the spot, but in 15 seconds. Yes, please, Matt.
Sure. I'll take the opportunity to actually wrap around a whole bunch of comments that Jeff, Fred, and May were making, which really is that one of the things that has become just painfully evident during the pandemic is the extent to which disparities and inequities are so prevalent, not just in the Medicaid system, but in the healthcare system writ large. And that you see that everywhere. You see that on racial lines, on ethnic lines. You see that on geographic lines. We talked about the distinction between urban and rural in terms of broadband access, but it's true in so many different ways. And I really think that everything that we do moving forward has got to be done through that lens of how are we making sure that the new policies we're setting, or old policies we're continuing, are focused on trying to bend the curve of some of those, of as many of those disparities as we can, and trying to be very, very purposeful around creating policy designed to bring those back in line.
That's excellent. Thank you for bringing that point to the fore. Any final comments from the other panelists?
I couldn't agree more, Matt. I think at the end of the day, healthcare is about people. It's about caring for people, all people. And at the end of the day, when you look at what we've done, what has been done collectively throughout this public health emergency for people in the interest of people, there's no reason to stop it. There's no reason to stop it. We should build upon it, not go backward, go forward in the interest of caring for all people, especially the people we've been missing to date, the people that slipped through the cracks despite our best intentions. And I think so much of what has been done in the last 2 years has worked to seal those cracks more fully. And I think we need to advance that. And I'm thankful for the work that's been done. I'm enthusiastic about the work that is yet to come.
Wonderful. Well, thanks to all four of you for your leadership, your expertise, for joining us today and participating in today's event. Thanks to the audience for your terrific questions. Hope you found today's event to be informative. Until next time, be safe, take care, and we'll talk to you soon. Thank you.
Thank you.